right, the time is 12:02. Welcome once again to Project First, Looking Back, Stepping Forward, a data analysis presentation with myself, Aleks Martin. I use she pronouns, Courtney Moreno, she pronouns, Jake Ketchum, he pronouns, and our Principal Investigator, Dr. Sara Glick, she pronouns. Project First stands for fierce, intelligent, resilient, strong, and truth. Project First Seattle is part of the National HIV Behavioral Surveillance Project with Public Health and Seattle King County. Good afternoon to everyone. Good noon if you are with us along the Pacific Standard Time. And if you are outside of that, good day to all of you, and hope that you are faring well during this unprecedented time. All right, let's move along into our data presentation. So for today's schedule, we will begin with a welcome and overview, and then followed by a preliminary project finding from Sara Glick, and then we will entertain Q&A from our attendees. So let's begin by acknowledging our First Peoples land. Here in the Seattle area, we are on Duwamish land. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. On behalf of Project First, we would like to extend our gratitude to our staff and our Community Advisory Board, which consists of a diverse cross-section that represents our beautiful community. We would also like to acknowledge our interviewers, Emmett, Ganesha, Lee, Manny, Rachel, Ricky, and Tyler. Our project staff consists of myself again, Aleks Martin. I use primarily she pronouns. I am the project program manager, field supervisor. I recently returned to public health after 10 years absence. I previously worked as a disease intervention specialist for about 7 years. In that time that I was away, I worked as a counselor at Seattle Counseling Service, a well-known LGBTQ behavioral health agency here in the Northwest. And after completing my Master of Social Work at the University of Washington, I was delighted to return to public health and to work with my amazing colleagues. And I'll start with Courtney Moreno. Courtney works for the HIV STD program at Public Health Seattle and King County, and is our data manager for the NHBS survey. She's a total nerd for the data and especially loves any time she gets to work with folks in the community to make the data work for them. Her favorite parts of being home more are making a hot breakfast, walking around Beacon Hill, and hanging with her new co-workers, meaning her partner, their 5-year-old kiddo, and 2 chihuahuas. Also, we have Jake Ketchum, our program manager with the HIV STD program at Public Health Seattle and King County. He is passionate about the HIV STD prevention with a focus on communities that have been disproportionately impacted. And outside of work, you can find him enjoying time with his family, traveling when not in the middle of a pandemic, spending way too much time researching cars of all varieties, and looking forward to his next delicious treat from one of Seattle's many great bakeries. And our Project First Principal Investigator is Dr. Sara Glick, an epidemiologist with the HIV STD program at Public Health Seattle and King County, and on faculty at the University of Washington. She conducts research and other evaluations related to HIV prevention with an emphasis on people who inject drugs and syringe services programs. Outside of work, you can find her riding her bike while wearing a mask and 6 feet of others, of course, cuddling with her calico cat, Pasha, and searching for the best Indian takeout in Seattle. And she thinks that she may have found it. Thank you, everyone. In 2003, CDC, or the Centers for Disease Control and Prevention, created what we now know as NHBS to conduct behavioral surveillance among persons at high risk for HIV infection. Now, what you ask is National HIV Behavioral Surveillance is, or NHBS. This is the process of conducting surveys in rotating and annual cycles in different populations at increased risk for HIV. What is surveillance? Public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. NHBS data are used to provide a behavioral context for trends seen in HIV surveillance data. It describes populations at increased risk for HIV infection and thus provide an indication of the leading edge of the pandemic. I would also like to add that we at Project First recognize that behavioral surveillance is in our name, and it sounds a little creepy, but it's okay to acknowledge that the data collection on behaviors and circumstances that might increase a person's risk of HIV. This is different than typical public health surveillance, which only collects data from people once they have an outcome. And our role and our goal of Seattle NHBS is prevention. And we also want to just acknowledge to help normalize scientific jargon into our daily lingo. And here are the three initial cycles of NHBS. MSM, which stands for men who have sex with other men. IDU, which stands for injection drug use or people who inject drugs. And HET, for heterosexually active persons. Now, coast to coast, county to city. Seattle is one of 22 large metropolitan areas participating in a national health survey funded by the Centers for Disease Control and Prevention. Each year, different populations are surveyed to learn about HIV prevalence, sex and drug use, HIV testing, and the use of local HIV prevention programs. This survey provides up-to-date information to help improve HIV prevention in King County. And Seattle has been an important and successful part of this effort since 2005. And here are the major cities involved in the study at the national level. And at this time, I would like to acknowledge our dear friends and colleagues at CDC, Taylor and Janet, for assisting us from start to finish and for the ongoing impact that this has on our community. Now, what is MSA? The general concept of a metropolitan statistical area is a core area containing a substantial population nucleus with adjacent communities that have a high degree of economic and social integration with that core. CDC analyzes this data for the MSAs to provide localized health information that can help public health practitioners identify local and emerging health problems, plan and evaluate local responses, and efficiently allocate resources to specific needs. For example, for the Seattle project of NHBS Trans or Project First, this includes Seattle, Bellevue, and Everett. And to be more inclusive, we identify with the King and Snohomish counties. The 7 sites that conducted NHBS Trans are Atlanta, Los Angeles, Nowlands, New York, Philly, San Francisco, and the Emerald City, Seattle. Data were collected to assess HIV prevalence and associated behaviors and other experiences important to the health and well-being of transgender women and gender diverse women, especially trans women of color. A little bit about our history. Locally, again, the Seattle NHBS Trans Project or site, known to the community and by many as Project First, began in June of 2019, so just last summer, and concluded this year in February. The study initially had one location at an old Tully's coffee shop in Pioneer Square in the downtown area of Seattle. And here are a few shots of our headquarters. That's little cubicle with toiletries, makeup, and condoms and lube. A couple of showcases here of some shoes, which we would like to share that these were donated by Seattle's very own Ben de la Creme of RuPaul's Drag Race fame. She's a size 9 and 10, by the way. So here's our 2018-2019 timeline, our 2-year timeline. In year 1, this is where we conducted our formative evaluation, which consisted of key informant interviews, community members that we felt had their fingertips on the community, the scouting of areas where we would conduct the interviews, staff recruitment, and interviews of our interviewers, our equipment, and supply inventory. In year 2, this is where we conducted our data collection. And this was conducted through a method called RDS, or Respondent-Driven Sampling. Now, what is RDS? This is when a small number of initial participants are selected, and which we call seeds, who complete the survey and then recruit their peers to participate. Recruitment then continues until the target sample size is reached. We would like to acknowledge our partners in this effort: Utopia, the United Territories of the Pacific Islanders Alliance, and Entre Hermanos, Seattle's Latino, Latina, Latinx, LGBT organization. As mentioned earlier, we started at one location at an old Tully shop here in downtown Seattle. And we added 2 more locations in South King County and the Central District. The South King County location was housed at Utopia in Kent, Washington. And the Central District location was housed at Entre Hermanos along Jackson Street. And I'd like to add that we were also plugged at Mucho Gusto La Grande on 99.3 FM. Now, cash incentives were conducted through the RDS method, where participants were given $100 cash, which included $25 for the anonymous survey questionnaire conducted via tablets, and $25 for the anonymous HIV testing, and $50 for the anonymous STI testing, which included chlamydia and gonorrhea. Participants also received an additional $20 for each referral, and each person received 5 referral coupons. Altogether, our participants were able to receive $200. And here are some samples of what the coupons looked like. If you notice, the amount is a little less. We just kept going up the ladder, but we started with $150. This is the one in English, which actually has the location in Kent at Utopia, and a Spanish version on the opposite side. Now, eligibility criteria for our participants, we had 117, the goal was 200, and of the 117, they were 18 years or older. They resided or reside in King or Snohomish County, which is the MSA, and they were male assigned at birth, and their gender identity was under woman, trans woman, or a gender not listed. We'd also like to share some highlights of our project. Additionally, eligible participants were offered free testing for both HIV and STI. The STIs were for gonorrhea and chlamydia in 3 different samples: pharyngeal, urine, and rectal. We also provided linkage to care for participants who were HIV positive via test and or self-reported, and any related resources. Not all of the sites were able to offer STI testing, and the various sites had different methods of giving test results. At the end of the survey and testing, participants were offered free hygiene kits, toiletries, makeup, shoes, clothes, and condoms and lube. Participants were also encouraged to visit our main location at the Old Tully's office for picking up supplies, use of our computer, snacks, coffee, tea, in addition to picking up their recruitment incentives. Regarding consent, confidentiality, and anonymity, all participants provided informed consent. Participants were also informed that all activities are voluntary and they may decline any questions and may cease the interview and or testing at any time. We also recognize that the transgender and gender diverse identity and narrative is complex, and no simple dictionary definition or survey eligibility criteria can definitively address this. We also address that all staff regarding perceptions on outward appearances and perceived presentation of the trans and gender diverse community. We address how social stereotypes may inform our decisions. Eligibility was based solely on our participants' responses to the questions. Eligible participants ranged in gender presentation and self-identity with their stages of transition, which truly reflect the fluidity of gender. They varied from those who have socially transitioned to those who have completed gender-affirming procedures. We'd also like to share that 20 of the 137 participants screened did not meet eligibility, and reasons varied from living outside of the MSA, so living outside of King or Snohomish counties. They were either assigned female at birth, and we also recognize that promotional materials also indicated trans, which can be a universal term to also include transmasculine or trans men or trans male. We'd also like to share with you during this period in 2019 that the project continued through the holidays. We also recognize for many LGBTQ, particularly trans members of our community, are often ostracized from their families, which often means that during the holidays, we don't have any family to spend time with or to celebrate with. So we thought to celebrate with them, and we organized an event called Transgiving Tea Time, a transgender Thanksgiving celebration. Here are some images from that event. All folks that are pictured here gave consent to our event photographer. These are our friends from Utopia in Kent. This is Atasha, one of our performers. This is Donato, one of our colleagues from Utopia who did a slam poetry performance. This is Lee. He is one of our interviewers. Our friends again from Utopia and community members. Our friends from Ingersoll Gender Center. Dee, one of our performers. Tanya, one of our performers. And if you notice, we actually have a banner as well on the very back, Project First, which stands for Fierce, Intelligent, Resilient, Strong, and Truth. This is Tofu, our security person dog at our headquarters. Now, moving on, the following is a snapshot of data collected from Project First, presented by Courtney Moreno and our Principal Investigator, Sara Glick.
Thank you so much, Aleks. I, of course, have the unenviable job of following you and Tofu, but I do promise to give the reins back to you after the data portion. We will be presenting some pies today, not necessarily Thanksgiving pies, but some pie charts. But I'll just quickly reintroduce myself. My name is Sara Glick. I use she, her pronouns. And before I dig into the data, I want to reiterate how grateful I am to Aleks and her leadership on this team and for putting together this event today. I'm also so grateful for our interview staff and, of course, to the participants who share their time and their stories with them. And finally, as Aleks has mentioned, Courtney Moreno is on the call today. She is the one who put together all of these analyses and slides and will be available during the Q&A to help me answer any questions. Now, before I jump into the data, the last caveat I have is that I just want to acknowledge up front that we were fortunate to interview 117 participants, but we do acknowledge that the sample is likely not representative of all trans women and trans feminine people in King County. So we are not making conclusions about that full population. The data we do have is a really rich snapshot of the folks that we were able to reach, and so we can learn a lot from them. I will begin by talking about participant demographics. Just trying to get my slides to advance here. First, with age of our participants, first you can see in dark blue that about a third of our participants were between the ages of 18 to 29. In green, another third or so were in their 30s. And then the rest of the colors show that about another third, maybe a little bit less, were 40 or older. Race and ethnicity was asked in 2 different questions. Race and ethnicity were asked in 2 different questions, which is fairly standard. The race question allowed people to select all that applied to them. And what this graph shows is that it does show all of the races and ethnicities that people select. So people can appear and do appear in more than one bar. What you can see first is that 7% of our participants identified as American Indian or Alaska Native, 16% as Asian, 18% as Black or African American, 21% as Hispanic or Latinx, 35% as Native Hawaiian or other Pacific Islander, and 32% identified as white. Overall, 82% of our participants were people of color, meaning that they selected any race or ethnicity other than white. The survey also asked participants what country they were born in, which is what we're going to talk about next. Oops. And this response was defined by the participant. The 3 most common responses were that 59% said the United States, 15% said American Samoa, a US territory, and 4% said Mexico. An additional 22% gave us a country, another country, but no individual country was greater than 4%, so we didn't list those individually. The survey also asked people for the zip code that they lived in, and the largest group of participants by far was from South King County, which we think is largely due in part to our site at Utopia, which is in that part of the county. We also saw 17% of people from Capitol Hill in the Central District, 15% were living downtown, 13% in South Seattle or West Seattle, 12% in North Seattle, 6% in East King County, and then 4% were from Snohomish County, which isn't included on this map. Regarding housing status, the survey included a couple of questions about housing. At the time of the interview, 21% of our participants reported that they had been living homeless at least some point in the last year. And of that 21%, 44% were homeless on the day of the interview. So that's about a little less than 10% of the full sample. 20% of our participants reported that they had been refused access to a shelter at one point in the last year for being trans. And among those who reported any bout of homelessness, we asked them how many days that they had spent homeless in the last year, and the median response was 80. So that's between 2 and 3 months in the past year. The survey also asked questions about employment, not and sexuality, but it asked questions about employment and health insurance. We did not define what employment meant, so the participant again could self-define this. It includes both full and part-time work. In dark blue, we saw that about 2/3 of our participants reported being employed. In green, about 3% were retired. In yellow, 10% reported being able to work for health reasons. And in blue, about 14% were unemployed. With respect to health insurance, we saw that 22% in dark blue did not have any health insurance. 29.9% or about 30% reported any form of private insurance, and about 48% reported receiving only public insurance, so only Medicare or Medicaid. Of course, these data were collected entirely prior to COVID-19. So I would certainly expect that now we would see both higher rates of unemployment and likely higher levels of not being insured if we were to do this survey now. The other thing I wanted to note with respect to health insurance is that it's not shown here, but we found that people who were born outside of the United States were more than twice as likely to not have insurance than people who were born in the US. We also saw that people who were Asian, Latinx, or Pacific Islander were the groups that were least likely to have insurance, whereas white participants were more likely to have health insurance. Okay, the survey included a question about participants' sexuality, which, like race, was a select all that apply type of question. So people can appear in multiple boxes here as well. 43% of our participants reported being heterosexual or straight, 25% reported being queer, 15% bisexual, 12% gay, 12% pansexual, 4% lesbian, and 3% reported being asexual. 15% of people also checked that they were an orientation that wasn't listed in the survey. I'm now going to present some data on sexual behavior, substance use, HIV, and PrEP. We found that 87% of our participants were sexually active in the last year, which the survey defined as having oral, vaginal, or anal sex. Among the 102 participants who were sexually active, they reported a median of 4 sex partners in the past year, which means 50% had more and 50% had less. We also realized somewhat late that the survey doesn't have a good measure of someone having a primary or a main partner or a spouse. So a very imperfect measure of this is that we found that 27% had 1 sex partner in the past year. We saw that most people reported at least some vaginal or anal sex without a condom, 83%, which for some people may indicate potential risk for HIV. And looking at the pie chart, the vast majority of our participants in green reported that their most recent partner had been a man, which is inclusive of trans men. 11% said a woman, which is inclusive of trans women, and 5% had a partner with another gender. I will pause here and just say that we don't have time to present much other sexual behavior data today. We collected a lot, though, that was part of the survey. So if anyone is interested in additional sexual behavior data, feel free to reach out to us because we have a treasure trove that we're happy to share with you. The survey also collected detailed data on substance use. And I did want to highlight just a few key points today. First, 28% of our participants reported at least 1 instance in the past month of having 5 or more drinks in a 2-hour period. And this is used as an indicator of binge drinking. 39% of our participants, which you can see in that dark blue wedge in the pie chart, reported using drugs other than marijuana, and 61% did not. The most common drugs reported by our sample included powder cocaine, which was reported by 19% of all participants, poppers also at 19%, and methamphetamine at 17%. Overall, 7% of our sample reported injection drug use in the past year. We were pleased to see that almost 90% of our participants reported that they had been tested for HIV prior to participating in the study. This graph represents when sexually active people were last tested for HIV by the number of months since their last HIV test. So for example, in the darker blue box, you can see that 39% of participants were last tested within the last 3 months. Among those who reported not having HIV, so they reported being HIV negative, and had had sex in the last year, 68% had tested for HIV in the past year, which is in alignment with our recommendations at King County. We also recommend more frequent testing, so every 3 months, for people who meet other criteria that might put them at higher risk for HIV, as well as for people who are using PrEP. So for example, in these criteria include reporting 10 or more partners, having condomless anal or vaginal sex with a partner whose HIV status was different from theirs or unknown, using poppers or meth, or having an STI diagnosis in the last year. When we look at that group within our sample, that's about 40% of our sample, they had of course, higher percent of HIV testing in the past year, just over 70%. Moving on to HIV prevalence, this was really one of the main objectives of this study, as Aleks highlighted earlier. We really didn't have any data on HIV prevalence among trans women here in King County. So as I mentioned earlier, I do want to reiterate that we acknowledge that this is likely not representative of all trans women in our area. This is representative of our sample. But in that sample, we found that 21% tested HIV positive. The vast majority of these participants already knew that they were HIV positive. Only 2% of our total sample newly tested positive for HIV during the survey. Our team, as Aleks mentioned, helped link folks anonymously to HIV care if either they were a new diagnosis or if they knew that they were HIV positive but weren't in care. And so that happened in both instances. I also want to add some important context here that many of our seeds, the first people that we recruited into this survey, they were recruited from an HIV clinic. And so, of course, we knew that they were HIV positive. And because of that initial recruitment, it may be that that led to a falsely high overall prevalence of HIV. We don't know what the actual prevalence is, but I did want to be upfront about the fact that we did recruit some folks who were known to be HIV positive as our initial seed participants. I also wanted to give you a little bit of context to where this prevalence fits within other populations that we work with NHBS. So our health department data think that we have about a 9% prevalence of HIV among men who have sex with men, about a 3% prevalence among people who inject drugs, and then a prevalence less than 1% among heterosexually active cisgender people. I will note, though, that in all cases, when we work with those communities through NHBS, we tend to get higher prevalences of HIV in our surveys. And so that might be another thing that we're seeing here. Now I'll turn for a moment to focus on people who were known to be living with HIV. This is a relatively small group of people, and in this group, we did find that 80% were in care, they were on HIV medications, and they had an undetectable viral load. And just to give you some context for that estimate as well, in King County, in our most recent surveillance report, we reported that we had an 84% viral suppression overall among all people living with HIV in King County, and 83% among trans people who are living with HIV. So this is very much in alignment with what we have seen in other health department data. The median age at HIV diagnosis was 28, and about a quarter of our participants had been diagnosed in the last 5 years, whereas half had been diagnosed more than 10 years ago. Now the chart below compares the race and ethnicity of people living with HIV to the survey group overall. And I'm going to walk you through this because it's a little complex. The green bars represent people who are living with HIV in this sample. And so you can see, for example, that about 40%, 41% were Black, 27% were Latinx, and 41% were white. For the most part, those green bars don't really align with the yellow bars. So they don't really align with the race and ethnicity of the survey overall. Of course, these are small numbers, but what we see, for example, is that less than 20% of the survey was Black. And so what this is telling us is that Black trans women had disproportionately high HIV prevalence in this survey. They had a 42% prevalence compared to the 21% prevalence overall. Conversely, the percentages of the Pacific Islander and Asian participants who were living with HIV were smaller than in the survey overall. And of course, this finding related to Black trans women is very important, and it aligns with what researchers have reported in other cities. I do want to be sure that I'm clear again about some context. Remember, these are very small numbers. In most cases, these are just single digits, and that we did recruit Black HIV positive seeds. And so I do want to be very cautious about drawing any firm conclusions, but I think these are important preliminary findings and the first data that we've had, not just on trans women, but specifically on Black trans women locally. So with respect to STIs, as Aleks mentioned, we asked about STI testing and in the survey, and over half of our participants, 54%, had tested for an STI. 10% of all participants reported that they had been diagnosed with an STI. But as Aleks mentioned, we also offered testing for chlamydia and gonorrhea during participation using specimens collected from the throat, the rectum, and urine. And from that testing, 14% of participants had a positive STI test. 11% tested positive for gonorrhea, and 3% tested positive for both gonorrhea and chlamydia. We did see that new STI cases were overrepresented among our participants from South King County. Our staff noted that many people who received a positive test were surprised, meaning that they were likely either asymptomatic or they just hadn't gotten to this point where they sought testing or had access or resources to get that testing. Aleks and her team were very diligent about ensuring that people were notified about their test results, both positive and negative, and then provided linkage to care and treatment when somebody did have a positive test. The survey included a handful of questions about PrEP, which for those of you who aren't aware stands for pre-exposure prophylaxis, which is when people who do not have HIV take an HIV medication, often Truvada, to prevent their acquisition of HIV. Of the 85 participants who did not report having HIV and were sexually active, 19%, that green wedge, reported taking PrEP in the last year. 26% had discussed taking PrEP with a provider, but weren't currently doing so, or weren't doing so in the past year. 42% had heard of PrEP, but hadn't discussed it with a provider. And 13% of these participants had not heard of PrEP prior to participating in the study. Of course, we recognize that PrEP is not recommended for everybody, and our recommendations do specify that PrEP is a better fit for people who meet certain criteria. And when we look at some of those criteria that I mentioned earlier, that group of people did have a slightly higher prevalence of taking PrEP in the last year, right around 21%. So in the group that is recommended for PrEP, we saw a PrEP usage prevalence in the past year of about 21%. I'm now going to switch to talking about some local questions from our survey. So it's NHBS lingo, and so let me explain that to you. The CDC gives us a core set of questions that we have to ask to all participants, but we are allowed to include a set of local questions that can be tailored to our local needs or local phenomenon. And so for Project First, our local questions were developed entirely by our Community Advisory Board. And so they reflect the priorities of that group and the communities that they represent. And so these questions, for the most part, were only asked in Seattle. They don't get shared with the CDC. Although I will say that a lot of sites were very interested in our CABS questions, and so we shared them with the other cities, and they certainly could have been asked elsewhere. We just haven't seen any reports yet. So sticking with the PrEP theme, we asked participants who didn't use PrEP why they didn't use PrEP. So among that group of folks, the most common response was that accessing basic needs, such as gender-affirming care or housing, was a bigger health priority to them. The second most common reason given at 49% was that people did not think that their risk for HIV was high enough to be on PrEP. 35% said that they didn't think they could afford it. 26% didn't know where to get it. 16% were concerned that it would make their hormones not work as well. 12% were concerned about stigma or judgment from the community. 11% didn't trust that PrEP worked well. And 2% didn't think that PrEP was for their community. And then 21% of people included another option, which was write-in. And the most common response was a concern about general side effects. When writing the PrEP questions, our CAB noted that some providers had been prescribing PrEP 211, which for those of you who aren't familiar, this is also called PrEP on demand. It's when somebody takes 2 pills the day before they anticipate having sex, 1 pill the day of and 1 pill the day after. And as you can see in the dark blue wedge, 22% of our participants had heard of PrEP 211 prior to the survey. And in the pink teardrop, we found that 58% of participants who didn't report having HIV and were sexually active said that they would be more likely to take PrEP if it were required every day. Now, PrEP 211 is not currently recommended in the United States. It's been studied and recommended in other countries, but it's currently not part of our standard PrEP care right now. There may be other people on this call who could chime in about this later, because we would be very interested to hear more about that. Oh, I already see somebody jumping in. It is recommended in the US in various locations, not just at the federal level. Thank you so much for that chat. It's recommended in New York State, New York City, San Francisco, and Los Angeles. Thanks. Okay, I see some additional clarification, so we can come back to that during the discussion. Thank you. Our CAB was also interested in collecting some additional information about exchange sex, sex work, or transactional sex. And we specifically asked if somebody had received something of value in exchange for sex in the last year. 30% of our participants said they had. And among that group, about 30% considered sex work as their job. Of the overall 30% of participants who reported any exchange sex, 37% said that they didn't use a condom at least a little of the time because they needed the money that they could get from having condomless sex. And also 17% didn't use a condom at least a little of the time because they were in a situation where it wasn't safe for them to use a condom. So again, I know I'm just giving you a snapshot of some data we have on exchange sex. If this is something that you or your organization are particularly interested in, we'd certainly be happy to work with you to look at these data more closely. To further assess people's general needs, we asked our participants if they had access to all of the resources they need to support their gender identity. And 69% of our participants said yes, and 31% said no. Among the 31% who said no, we asked we really asked about the results, what the results were of this lack of resources. So 58% reported that this lack of resources to support their gender identity made them more likely to avoid going to the doctor. 33% said it made them more likely to use drugs or alcohol. 31% said to sleep in places that aren't safe. And 25% said that it made them more likely to have unprotected sex. We also asked specifically about trans-affirming healthcare and asked how their experiences had been accessing trans-affirming care that was right for them. 31% said it was easy for them, 48% said that they felt neutral about it, and 21% reported that it had been difficult. So for the next 2 slides, I'm going to show some responses that are from that dark blue wedge, specifically among the people that reported that accessing trans-affirming care had been difficult for them. First, we asked about difficulty in finding a provider, and specifically, we found that in that group of that 21%, 92% of them said that they had had difficulty finding a provider who supported all of their identities. 87% had difficulty finding a provider who was trans-affirming. 83% had difficulty finding a provider who they trusted. 79% finding a provider who wouldn't judge them for the types of sex that they had. 71% had difficulty finding a provider who wouldn't judge them for the type of work they did. And 46% had difficulty finding a provider who wouldn't judge them for their use of drugs and alcohol. And then we also asked about some more general access issues. And again, among that group of folks, that 21% of folks who had difficulty accessing care, among them, 92% had found it difficult to get insurance to cover care, including facial feminization, tracheal shave, or hair removal. 83% had difficulty financially supporting themselves when they were recovering from gender-affirming services. 75% had difficulty getting a provider to approve their gender-affirming care, for finding a gender-affirming clinic that was easy for them to get to, and for consistent access to hormones. 68% had difficulty enrolling in health insurance, as well as finding a provider who would prescribe the hormones they wanted. And then 58% had difficulty getting time off work to have and to recover from gender-affirming services. Anyone who has lived in Seattle for more than just a few years knows that we've really undergone substantial gentrification. But of course, this has been going on for several decades. And it's resulted in a loss of affordable housing, as well as an increase in displacement for many people living in parts of Seattle and King County. So our CAB was really interested in this and asked participants if they had been negatively impacted by gentrification. And so 50% said yes, 50% said no. Among the half of participants who said yes, we asked them what those impacts had been. 63% of them said they couldn't find housing that's affordable. 54% have to travel farther to get their needs met. 53% have had to move around a lot. 44% reported being more isolated. 41% reported having to sleep outside in a shelter, in a car, or couch surf. 22% said that they felt less safe where they live. And 17% reported having been evicted. My second to last data slide is about where people reported feeling safe and not feeling safe. And I do want to highlight here that the responses you see here are just a sample. We actually collected more data on this. So again, if safety is something that you or your organization is interested in, please do reach out. We'd love to share this and talk about this with you. Let me orient you to this slide. It's a little complex. The dark blue and the light blue boxes reflect the percent of people who agree that they felt safe, whereas the pink and red boxes reflect the percent who didn't feel safe. And so among the 5 choices here, the areas with the least blue, or the least safe, were public bathrooms and public transportation. About 75% of people reported feeling safe walking around their neighborhood, and then higher proportions of people reported feeling safe when they went to the doctor, as well as in the place where they slept. And then finally, our final slide, we asked people where they get the support they need to live their best life. And I'm not going to read all of these out loud. I'll let you digest these on your own. And as you do that, I am going to turn this back now to Aleks to wrap up with a few more of our qualitative findings.
We have a request from one of our panelists for accessibility reasons, and we thank you for reminding us. To the question, I get the support I need to live my best life. 97% myself, 92% from the trans community, 92% as well from friends, 83% from chosen family, 79% community organizations, 67% from significant others, 55% from family of origin, and 46% from spiritual sources. Thank you, Denny. Thank you, Sarah, for that data presentation. At the end of the survey, we asked our participants to share their thoughts in this free-form question of, if we lived in a world where all trans people were fully loved and supported, what would your life be like? We did a little Wordle here, and here are some of the highlights. Gender, amazing, comfortable, great, safety, exist, focus, happy, and of course, life. And here are some quotes from some of our participants. I would no longer argue my validity. Better, I could walk around the street and not have to fear for my safety. I would not have to worry about family and friends. I would be able to get respect for people while not having to compromise my gender expression. How it's supposed to be and should have been, happier. I would have the freedom to make my own decision without fear for my mental or physical safety. I would be able to comfortably exist within my own skin and brain. I would not have to constantly question my identity. I would feel like I'm allowed to exist. It would be amazing, beautiful, and colorful, and something I can't wait to wake up every morning to. More fulfilling and emotionally healthy and comfortable in my own skin. Probably a great life with no hate and acceptance. And I think everyone would live happy like that, especially trans women. Just gonna leave this here for a couple of seconds for folks to read through some of these powerful words. Actually, all of them are powerful words. All right, next steps. Well, we hope to promote this data to be utilized by community organizations, different programs for accessing and utilizing and maximizing funding and grants that impact the trans community. We want to continue to advocate, and we want to share with you that we've been able to advocate for trans masculine, trans male inclusivity with the 6th cycle of the MSM arm of NHBS. And of course, we want to hear from you about other ideas. Let those light bulbs shine. Some of the topics that are available of interest with you folks, and please, this is not an exclusive list or an extensive list. There are topics around abuse and harassment, discrimination, healthcare access, incarceration, mental health, sexual behavior, sex work, substance use, and so on. All right. We would like to open it up for our question and answer portion. Question is, what entity required or made the decision to exclude trans people assigned female at birth from participation? Followed with, was there ever discussion of changing the name of the program to make that clear? I want to call out our principal investigator perhaps for that first question, and if I can maybe have Jay Ketchum, our program manager, perhaps address the second question. Sarah, you've got the floor.
Yeah, sure. I found, I want to make sure I answer it. So right, the question about why people assigned female at birth were excluded from participation in this study. This came up a lot in discussions with community after the fact. We weren't locally not involved in the decision to design the survey, and it was focused on trans women and other trans feminine people, specifically because there has been a notable higher prevalence of HIV in this population in the research that had been done. And so the CDC wanted a survey that focused solely on that group. And so that was basically the protocol that we were able to apply for. But to your point, we certainly heard that from other people, and we passed along that information to CDC, so they're certainly aware. And to that end, we will be, and somebody else actually asked this question, it might be the same person, we will be able in Seattle to include trans men and trans masculine people who have sex with men in our MSM survey, which will be rolling out shortly this fall as well as next year. Previously, trans men who had sex with men were not eligible to be included in our MSM survey. And based on community feedback like this, we were able to advocate to conduct a pilot to include folks in our survey this year. So we're really happy to be able to do that. I don't know if anyone else from my team wanted to add anything to that. If I missed anything, please do chime in.
Thank you, Sarah. I want to open the floor to Jake Ketchum. Again, the question is, was there ever discussion of changing the name of the program to make that clear?
Thank you, Alex. Yes, actually, there was a lot of discussion around the name of the project and how to promote it with our community advisory board. As you mentioned, we had a really incredible group of people from the community that shared their thoughts and ideas. And it was, the goal was to sort of strike a balance of acknowledging and lifting up and having something that kind of represents trans women of color in particular, as that was sort of the focus. But also not having anything so explicit that it could potentially out people that may not want to be seen as being part of a survey that was specifically for trans women. So I will say, because of some delays at the federal level, the project wasn't able to roll out with our initial timeline, which would have given us a little bit more time. And so we were on a little bit of a time crunch as well. So. But I do want to acknowledge the great work of the CAB, and it was really amazing to get to be there for their discussion around the name of the project. Ultimately, it was a brainstorming session, kind of that everybody was tossing out words that made them think of trans women, particularly trans women of color, and empowering them and their resilience and strength in the community. And then taking all of those words and sort of narrowing it down to the 5 that made up the acronym first. So that's kind of how that all came about.
Thank you, Jay. Also, I'd like to share just from a lay perspective, I think historically, trans men, and we know the data isn't robust for all trans individuals that impact HIV prevalence and acquisition. because of that, many trans folks, both transmasculine and transfeminine, have not been included. And so this was pretty historic. And one of the ways that we were really able to invite folks to participate in this is to say, this is the first time that this has been recognized. So we really want to make sure that you know this, and if you're able to participate in it, because we need participation in order for this to be successful. And then of course the distinction of transmasculine, transfeminine, and that's why the next phase for this is we're able to invite folks in the MSM6 cycle to include trans men. And to follow up that there's another question that kind of we would like to elaborate. I wanted to call Courtney Moreno, who analyzes our data and really digests it. The question is, could you elaborate on what it means to be trans men or transmasculine, to be included in the MSM6 cycle? Maybe to expand, I hope that this is okay, maybe specifying the identities or the definitions and how we went about it. Courtney?
Sure. I think we're still in process. You know, we haven't started the MSM6 cycle quite yet. We've been, Anthony, who runs that section of the cycle, has been doing formative research to talk with folks in transmasculine community about what it would mean to be included in a survey like that, how folks feel about being included in a survey like that, and what it would look like. So I think we're embarking on those. I think we want to keep it really open based on formative research in terms of people's identities, and don't really want to restrict who's included based on identity, really strict definitions of it, but we'll be talking more. So we want to be more open in terms of who's included, and then just continue talking with community about how to talk about the data that we get. And as Sarah said, that's just been based on a lot of feedback that we've gotten from community members about excluding trans folks from the MSM cycle and from other cycles of NHBS. So we want to continue to promote the inclusion of trans folks in all cycles of NHBS. And from data that we have, that the cisgender MSM that we've been surveying are having sex with trans folks, and specifically with transmasculine folks too. So we want to make sure we're including them. I just saw the chat came through at the end, and apologies if I'm jumping ahead, Alex, but I just want to acknowledge that, yeah, the term Project First isn't trans-specific at all. And in terms of the organization calling it NHBS Trans, that coming from the CDC, I don't believe there was any discussion. We did give them feedback around that, and around trans folks, including transmasculine folks as well, and including folks who were assigned female at birth, and that being confusing about the name. And I do really appreciate the feedback that wasn't clear about this presentation. So that's really good feedback to us in terms of how we talk about this with the community and promote the data. And if other folks want to chime in as well, please go ahead.
Sure, yeah, I'd love to. More of the larger picture around Project First being the name of the project. I want to focus to and really provide gratitude to the Community Advisory Board, who they worked very diligently under Jake's leadership before I even came in, that they had extensive conversation around what that name should look like. And within that discussion of the Community Advisory Board, they came up with FIRST as an acronym. I think also from a promotional sort of perspective, I think with projects like these or studies like these or programs like these, when you are looking for folks, sometimes having a too obvious name might actually yield, from a testing jargon, like a false negative, meaning if people knew exactly who you're looking for, because we are relying on how they're answering, we might just get folks that say, yes, I'm trans feminine, yes, I'm a trans woman, but in reality, they might actually not be. And because of the incentive piece, it might actually skew our numbers. And I thought that might create a problem. Also, because our method was through the RDS system, or the respondent sampling, we actually relied on the word of mouth of community members. So being part of the community myself, I saw that as really the essence and the catalyst of how we were recruiting people to ensure that it was truthful, right? And it was actually within the community, as these folks, the seeds and the participants, as they were actually recruiting folks, because technically we weren't marketing it. Because if we marketed it, then it's not the RDS system at all. That would be an entirely different system of sampling our participants. I hope that gave some clarity a little bit. But I also do agree with your point, IW. Thank you so much. And please don't apologize. We want to make sure that it's clear also for folks. Thank you very much. Appreciate it. Jake, Sarah, Courtney?
Hi, Alex. I just wanted to really quickly acknowledge as well. We did have a little bit of a false start in 2018. There was an administrative delay at the federal level, and previous staff who had worked on the project worked really hard to convene a community advisory board that had a lot of input, especially with our first round of locally specific questions. A few of those original CAB members did continue on when we were able to regroup almost a year later, but just wanted to acknowledge that the support across the community really helped lift this project up and make it successful. And that started with original staff and community advisory board in 2018. First question is, since the local surveillance question sought to illuminate the intersection of HIV risk with issues such as unequal access to housing, employment, healthcare, the prison industrial complex, and incarceration, as it relates to the lives of trans women and trans feminine communities, especially trans women of color, will you plan to share seed responses to these questions with King and Snohomish County organizations and community groups to help advocate for equitable access to social health, educational, and employment resources for trans women and trans feminine folks of color, and how?
Thank you, Jake.
I can start with that. First of all, thank you. That's a terrific question slash recommendation. And this is exactly the sort of action that we want to take with our data. And so absolutely, I think we still have to think about how we're going to package that and do it. I think we still need to figure out if it's more effective to do a report, to host another webinar. We also want to make sure that other community organizations who might be working with some of these entities more directly also have access to these data and can use it to advocate either for their own funding or for more access or services. And so I'm going to take this comment and copy and paste it into my to-do list, and I really appreciate it. I don't know if anyone else on the team had anything else to add to that.
There was just a follow-up comment to the questions stating a common complaint from marginalized communities being studied is that their knowledge and wisdom is collected but not utilized. I think that went to the previous question.
Mm-hmm.
Thank you, Jake. Courtney, we have a data question. Do you have data about the percentage of Seattle MSM who are not knowingly HIV positive who reported PrEP use in the past 12 months to compare to the 18% among this current study sample of trans women and trans feminine people? That would be a cross comparison of the other study, huh?
Yes, we do have that data. I don't know it off the top of my head, but I can quickly look while we're doing this.
All right.
Sarah, you may know it off the top of your head, so feel free to chime in. I can look at a past presentation to grab it.
Why, yes, I was actually just looking at this yesterday.
Yay!
So across a couple of surveys, which primarily include cis-MSM, among the group in which PrEP is recommended, we're close to 50%, or at least we were a year ago. That I'm hypothesizing is probably lower right now during the pandemic, although I don't yet have data to show that. But it was close to 50% among the cis-MSM in whom PrEP was recommended. Among MSM, kind of in general, it's probably closer to 20 or 25%.
I think this might be a good opportunity to just mention, because I think there was an earlier question about the inclusion of trans men in MSM-6, and not so much how trans men are defined, but what is the MSM-6 cycle. So the data that Sara is speaking to was collected in the last MSM cycle, which was 3 years ago, and then we're about to start another one, hopefully sometime in September. But typically it looks like going out to venues and recruiting people in places that they are. We do formative research to learn from folks where we might be able to reach men who have sex with men. So it's done a little differently than our other cycles where we recruit initial seeds and ask them for peer referral. However, this year, in light of the pandemic, it's going to be way different. And, you know, Jake, you could speak to this more than me, but there'll be a lot of recruitment done online, and there will be peer referral, which we think could be a really exciting opportunity to reach folks that we typically don't get to reach because part of the protocol has us, you know, often at bars and things that not everyone attends throughout the county.
Thank you. Jake, it looks like we have 4 comments or questions in the Q&A box.
Sorry, I was muted there. The next one is, were the numbers significant enough on the questions about reasons for not using PrEP to identify if those who felt they were not at risk for HIV truly had HIV risk factors that would make them eligible for PrEP?
Courtney, do you want to take that one? I think we were just looking at or talking about that yesterday.
Sure. Yeah, we did try to further restrict that data by not just folks who, let's see, did not report having HIV in this slide and also were sexually active, but by the other criteria that Sara had mentioned of that are used for recommending testing and PrEP, testing every 3 months in PrEP. So 10 or more partners and condomless sex with a partner of HIV positive or unknown status. And we found that they weren't terribly different than the other PrEP numbers, so they were really similar. I think that we were still just a couple percentage points below what was presented in terms of not feeling that they had high enough risk to be on PrEP. So it was very similar, but we could certainly get more specific data if you'd be interested in restricting it in another way.
The question is, for the 35% of people who said they didn't think they could afford PrEP, did the survey project inform them that there are ways to get PrEP for free or for extremely cheap in Seattle?
I can take this one if you
Go ahead, Courtney.
Yeah. Yeah, they did. So the participants had like a counseling session after they got their, well, before and after they got their HIV results, after the survey was over, and they discussed things like that from the survey, access to PrEP, PrEP referrals, talking also about the other data point about folks being concerned about PrEP making hormones not work as well. So all sorts of those kind of questions were answered after the survey.
Correct. And then to also point out that, like, just organizationally, structurally, that the counseling happened after the survey, the questionnaire was being conducted, so that it would not influence how they answered. And then the conversation that happened prior would just be like a general conversation between the interviewer and the interviewee. But then afterwards, after both the questionnaire and the testing, that the counseling was conducted afterwards. And then the last point of contact would be actually with me when I would give them their incentive. If they had any follow-up questions, I would also provide them the resources as well. And then we also gave them a project number that they could call at any moment, at any time, if they had questions that maybe perhaps they forgot, or they were maybe a little embarrassed to ask and felt like they were, exposed in our headquarters. In addition to actual resources with their phone numbers locally, at least for the Seattle and King County and Snohomish areas. Let's see, another question. Did any of the participants initiate PrEP after the survey counseling based on those referrals, to your knowledge? I can quickly say it's difficult for us to assess that because it was anonymous. In the event that we would even know, it would it would impact, gravely impact the anonymity and confidentiality of the survey itself if we knew that information. Unfortunately, we don't. Well, fortunately and unfortunately, we don't because of the nature of the survey being anonymous. Any other thoughts from our staff? Dr. Steckler, can we be clear that PrEP is recommended for anyone who is at risk for HIV, but that Public Health Seattle King County makes a stronger recommendation for starting PrEP among persons with certain behaviors, i.e. Meth use, it's moving up, history of syphilis or rectal gonorrhea, but we want all other folks to have conversations about whether PrEP is right for them. Absolutely, especially if you are engaged with a primary care physician or a medical clinic or a health clinic, please have those conversations with them. If not, there are many programs out there, particularly with Public Health King County, the sexual health clinic that can provide you this information. Also, various studies on PrEP that are out there. One of them is with Dr. Joanne Steckler through Gay City and other locations. Other folks that want to chime in on that, a comment from Dr. Steckler?
I would just add to that I agree, and thanks for the comments, Joanne. At Public Health, we are having discussions about expanding who we're able to offer PrEP to, both out of the sexual health clinic and other locations as part of the ending the HIV epidemic. So hopefully we'll be seeing some changing guidance soon.
Comment or question, how would it impact the confidentiality and anonymity of the survey to know whether anyone made a PrEP appointment? Well, it would be a break of confidentiality and anonymity. It would ruin the relationship of our participants and us, the credibility and of the study if we actually knew that. And even if it was a number, I can also share that many of our participants were really asking that question, is this really anonymous? It was very important for them to know that this was anonymous. I think there are many different types of people who won't care if your name was included, but it was important for us to keep that information anonymous. Even if it was just a number, particularly our sample size was pretty small. Even if we say, and I'm just throwing a concept here, like what if I was identified as the redhead? We had one redhead, for example. If I was the one redhead, that is me. I'm not a redhead, but that would really feel like my confidential information and my identity was violated. I think it's just really holding on to the credibility of the study and the project.
And just to clarify that, we didn't collect anyone's names, and so sorry, I don't know why I said it became more.
Yes, yeah.
So we didn't have a way to follow up with them. So we don't have a way of collecting that information later to know if they were actually made it to a PrEP appointment. So it's, as you said, both fortunate for anonymity, but unfortunate for being able to assure people's linkage to their referrals.
If it's helpful, the HIV testing that was conducted, if their status was unknown, was conducted there. And their result was given during the survey, during the questionnaire. And then also for the STI results, I was responsible for calling them if they were willing to give a contact number. And we opted to only do a phone number versus an email. That was the most confidential way of letting them know. Also, there was a question on, could I leave a message if I did catch them, if it was only voicemail? So there were, sort of these like caveats to ensure that the right person with the right result is receiving the results. And it took roughly anywhere from 1 to 2 weeks. Question, were participants enthusiastic about this research? Did the study team note any patterns in participants' comments or opinions about this research topic, HIV/STI prevention, while conducting the study? Maybe the first one we want to address is it wasn't research, right? I think for many folks, at least the ones that I was able to converse with as they stepped away, the whole word research is kind of overwhelming to a lot of folks, and historically too, trans women in particular have not been included. So there was a lot of like, is this even for real? Or what's this about? Like, I've never been asked this before. Like, what's going on? However, because of the RDS method, it was their peers, it was part of their community, it was part of their circle. So we entrusted that there was an existing trust within their peers, that we relied heavily on that relationship. For that reason, there was enthusiasm, because if there's the seeds, ideally would have been their popular opinion leader, that they would believe their experience, that they would believe what they're saying. So there was enthusiasm on that end. And then for folks that came in as well that still had a lot of questions, they had that initial interaction with me. I said things that, that this is the first time that we are including trans women, and we really advocated for this. We wanted to make sure that the lives and the stories and the narratives, of trans women, trans femme, gender diverse femme folks were seen and heard. So there was a lot of enthusiasm on that end. Some people understood the historical implications of research that included and excluded trans women, trans femme folks. So it was mix and match. Maybe there was a minute number of people did not care for the incentive, but actually wanted to be a part of it regardless of the incentive. Yeah, but overall, I would say people were enthusiastic, the folks that did participate. I can't remember folks, and I know that it was voluntary. We told them that they could stop it at any moment. I believe everyone started from, they started from start to finish, including the testing as an option. Sarah, Jake, Courtney, around enthusiasm. I guess because I was in the field, I got to see more of that subjective observation. And again, it's anecdotal. This is not part of the data. It was just my eyes using this as a lens. Thank you for that question, though. Oh, Lester is sharing with us that Entre Hermanos, one of our partners, will have their first PrEP clinic by the end of this year. Felicidades. Oh, very great news.
Somebody asked if we could compare the 81% viral suppression in this survey to data from specifically the last MSM survey. Gosh, I don't know the data from the NHBS survey, Courtney may, but what the data I do have is just from our routine countywide HIV surveillance data, which includes everybody. And in that data, we do have viral suppression. About 84% of all people living with HIV are virally suppressed. And I can't remember the number for MSM specifically off the top of my head, but it's about the same.
In the last MSM cycle, of folks who already knew their status as HIV positive, 97% were currently taking antiretrovirals and 89% had an undetectable viral load.
Project First is grateful for the generosity of our study participants and their critical contribution in furthering the conversation and inclusivity of the vital need to address the sexual and overall health of the community. We also deeply appreciate the field staff, including the supervisor and interviewers who recruited participants, promoted the survey, and supported participants through the survey, testing, and counseling process. The project could not have occurred without support from community partners housing the project and referring participants, Utopia and Entre Hermanas, as well as the dedication of the Community Advisory Board and the folks at CDC, especially Janet Burnett and Taylor Robbins, who provided us guidance and support from start to finish. On behalf of Project First, our Principal Investigator, Sara Glick, Jake Ketchum, and Courtney Moreno, thank you so very much. And we will be in touch soon and share with you the recording of this if you'd like to share it with other folks and if you have other data needs. Thank you very much and have a great day, everyone. Stay safe and wear a mask.